Hi everyone. Now in continuation with the central nervous system, we will be discussing the diseases and their treatment. Now today we are going to take the brief introduction to a very common problem, that is depression. Now depression, as we all know, is the most common mental problem in today's society, and it is, you can say, so much common, or it is becoming so common that it is no more an exclusive domain of a psychiatrist, but it is also treated by other specialties, including primary care physicians or general practitioners. Now, we classify depression into three major categories. One is a major depression, which is also known as unipolar depression. The second one is persistent depressive disorder known as dysthymia, and the third one is bipolar disorder, which is mania associated with depression. We'll discuss this bipolar disorder sometime later. Today's our main focus will be on unipolar depression. Now this condition is pretty common. As we have seen, it affects both females and males. The problem is more in the females as compared to males. The normal characteristics are sad mood, pessimistic worry. Now this is important because people are worrying with a negative thought, with the pessimistic thoughts. Lack of interest in the surrounding, mental slowing, poor concentration, not able to concentrate on any work or studies, etc. There is a lack of sleep or there is excessive sleep. So there is some kind of sleep disturbance. There is a weight loss or weight gain as a result of overeating or undereating. There is a decrease in libido, there is sexual desire, and quite often there could be a suicidal ideation in the patient. Quite often you may find patient with depression complaining of physical symptoms or somatic symptoms, like there could be pain like headache, backache, abdominal pain, etc. There could be tingling, and these features of depression, that is the mood changes and the somatic symptoms, they usually persist more than 2 weeks to classify as a definite case of a depression. Now, depression can also occur as a result of several other illnesses, or even it can be drug-induced. Some of the common diseases which are likely to cause depression is hypothyroidism, diabetes, myocardial infarction, cancer, Parkinson's disease, and several chronic inflammatory diseases like rheumatoid arthritis, Crohn's disease, ulcerative colitis, and so many other chronic conditions. It could be as simple as chronic osteoarthritis in the patients. Now, few general points which are important to note about depression, that this is a condition which is underdiagnosed and also it is undertreated. We may also say that this is quite often wrongly diagnosed and wrongly treated. Ideally, the depression should be diagnosed at an early stage for having a better results, and the response of depression should be evaluated clinically. Now, this is something which is very significantly missing in the treatment of depression, because the patient goes to the doctor, he is prescribed with antidepressant drugs, and then after 1 or 2, 3 months' time, he never comes back to the same doctor. So there is a challenge in clinical assessment of the response. Then the clinical assessment of depression is important, or why it is required to know exactly whether the treatment is successful or not. Also, it gives a guidance for continuing the same drug or the same treatment. It may require some dose adjustment, it may require some adjuvant treatment, or it may require some alternative therapy. Now, drug therapy of depression, what we call as pharmacotherapy, if we look into the mechanism, how does it work? Primarily, most of the antidepressants, they enhances the serotonergic and or noradrenergic transmission. So basically they affect 5-HT and noradrenaline transmission into the brain. Also, the long-term use of these antidepressants, they affect the neurotropic factors, they induce the neurotropic factors. The most commonly known for depression is BDNF, that is brain-derived neurotropic factor. On the long treatment or the chronic treatment of antidepressant, there is increased neurogenesis in hippocampus. There is increased sensitivity and increased density of various receptors which are favoring for antidepressant response. There is also certain novel mechanisms which are being explored or recently found, like NMDA receptor. We have seen in the previous presentation that glutamine is an excitatory neurotransmitter and it has got 3 receptors: NMDA, AMPA and kainate. Now this NMDA glutaminergic receptor antagonist, ketamine, which is a well-known anesthetic drug, causes very rapid and persistent effect in cases of depression, especially those who are not responding to any other drug treatment. So this is relatively a new launch, or you can say new observation. Ketamine and its derivative can be used as a treatment for depression, especially in resistant cases. Now before we go to the drug, let us understand the mechanism. How does it work? As we have seen in the previous slide, we talk about that it enhances the noradrenergic and serotonergic transmission. So how does it happen? So let us see the noradrenergic neuron first. We all know that there is a presynaptic neuron, there is a postsynaptic neuron. And if you see noradrenergic neuron, the presynaptic part, you can see that the neurotransmitter noradrenaline, which is synthesized into the presynaptic neuron, is stored into the vesicle. And this noradrenaline can be metabolized by an enzyme called MAO, that is monoamine oxidase. And this noradrenaline is converted into inactive metabolite. This is point 1. The point 2 is the noradrenaline, once it is released from synaptic terminal, it goes to the synaptic junction or synaptic cleft, and in that case the noradrenaline, about 80 to 85%, is again taken up back, you can say reuptake, by the presynaptic neurons. So majority of the noradrenaline is reuptaken by the presynaptic neuron, and 10 to 15% is acting on the postsynaptic receptor, say alpha receptor in case of noradrenaline. So this is how the noradrenergic neuron, they are working. Now if we see this information, that the enzyme monoamine oxidase, which is metabolizing noradrenaline into presynaptic cleft, if it is inhibited by the drugs which are inhibiting MAO, we call them as Mao inhibitors, they will have more noradrenaline available for future release, and so they will have an antidepressant response. And that is how the Mao inhibitors are used for depression sometimes. Similarly, if we come to the synaptic junction, as I have told you that 80 to 85% of the noradrenaline is reuptaken. Now if you inhibit this reuptake mechanism by drugs which falls like TCA, which is tricyclic antidepressants, or SNRIs, that is selective noradrenergic reuptake inhibitor. Now these drugs will prevent or inhibit the reuptake of noradrenaline into the presynaptic neurons, causing more concentration of noradrenaline into the synaptic cleft, causing more noradrenergic transmission. So that is how the TCA and SNRIs are working as an antidepressant. Now similarly, we see the serotonergic neuron, almost like the same, with the difference that in place of noradrenaline, the serotonergic neuron, they synthesize 5-HT as the major transmitter into the presynaptic neurons. This 5-HT is again metabolized by the same enzyme MAO, and so any Mao inhibitor will also accumulate 5-HT having antidepressant effect. Similarly, the 5-HT which is released from the presynaptic neuron into the synaptic cleft is reuptaken by the presynaptic neuron, like in case of noradrenergic. So now if this reuptake of 5-HT is inhibited by a drug like TCA, Tricyclic Antidepressants, or SSRIs, that is selective serotonin reuptake inhibitors. Now these two drugs again, they will cause more accumulation of 5-HT into the synaptic cleft, causing more serotonergic transmission. So with this we find there are two things are common. Mao inhibitors as well as TCA, that is tricyclic antidepressants, both are working on noradrenergic and serotonergic neuron by the same mechanism, preserving more noradrenaline in the noradrenergic and more 5-HT into the serotonergic neurons, and that's how they are acting as antidepressant. Now SSRIs are specific group of drug which are essentially inhibiting the reuptake of 5-HT and are very specific drug nowadays for the treatment of unipolar depression. Now let us understand the clinical perspective of depression. Once the treatment is started, most of the time there is a therapeutic lag of 3 to 4 weeks. So what is therapeutic lag? The therapeutic lag means that patient will take almost 3 to 4 weeks to show the improvement in the symptoms with most of the antidepressant drugs. And the interesting part is, once the treatment is started, the first improvement is seen in the sleep pattern, followed by mood enhancement, and then lastly, there is improvement in the cognitive functions. The duration of treatment of with most of the antidepressants requires 6 to 12 months of treatment. But the simple point which is often referred by the psychiatrist is that the duration of treatment should be considered total number of months, total number of period of disease duration plus 9 more months. So say for example, if the patient has got a depression in the last 3 months, then the minimum treatment should be 3 plus 9 months. If somebody is diagnosed with a depression just 1 month back, the minimum treatment should be 1 month plus 9 months, that is 10 months. So this is how it is considered, but it is not a mathematical formula. Overall, it depends on the clinical assessment, but usually it requires a treatment for a couple of months. Now the patient having chronic depression, which is going for more than 2 years, they usually require treatment almost for the lifelong treatment. And the treatment, if you consider the clinical outcome of the treatment, with most of the drugs, you will find that 2/3 of the patient, they show the improvement in the symptoms, and 1/3 patients show complete remission of the disease. Now coming to some of the antidepressants, they are typically classified into first generation and second generation. The first generation drugs are tricyclic antidepressants and monoamine oxidase inhibitors. As we have seen in the mechanism that these two drugs, that is first generation antidepressants, they are affecting both 5-HT as well as noradrenaline. The second generation drugs, which are more selective, one is SSRIs, which are selective serotonergic reuptake inhibitors, and other one is selective noradrenergic reuptake inhibitors, SNRIs. Now the second generation drugs are considered to be safe. They are considered to be more useful in terms of tolerance, and patients are usually able to tolerate these treatment in a better way. And that is how the second generation drugs are the first choice and the first generation drug has become the second line treatment in most of the cases. Besides this first and second generation, there are a few specific drugs which are categorized entirely separate, like ketamine. We have seen it is an NMDA receptor antagonist, which is useful for resistant depression, having a very kind of a complex, or you can say unknown mechanism. How does it work in depression is not well known. Similarly, we have a drug called Bupropion and vortioxetine. Now, when we see tricyclic antidepressants, the drugs are like imipramine, desipramine, amitriptyline, nortriptyline, trimipramine, doxepin, and amoxicillin. So these are the drugs which are considered as tricyclic antidepressant. And as we have seen, as I have told you, that these drugs are not the first line treatment anymore because of their potential side effects, which are very mixed kinds. They have antihistaminic effect, they have got anticholinergic effects, and so cause a lot of unwanted side effects. That all we will discuss when we are dealing with individual group of drugs. Then coming to Mao inhibitors, the Mao inhibitors are having, or you can say monoamine oxidase enzyme is basically having two different isoenzyme types. One is Mao A and another is called Mao B. Now Mao A enzyme is present into the GI tract and the liver, and the selective inhibitor for Mao A is moclobemide and iprobemide. There are a couple of non-selective Mao inhibitors. When we say non-selective, means they inhibit both Mao enzyme as well as Mao B enzymes. So these non-selective Mao inhibitors like phenylsapramine, phenylazine are isocarboxazide. They are available, of course, in different countries and in most of the countries rather, but they are not very preferred drug because of their potential toxicity, side effects. They are very much known for their drug interaction profile. They are known for their food interaction profile, especially with a drug especially with a food which contains tyramine. That we will discuss, of course, later on. The another inhibitor of Mao is called Mao B inhibitor, which is known as siligulin. It is more selective for Mao B inhibitor, has got relatively less side effect as compared to the non-selective drugs, or Mao A even for that matter. And it is available as transdermal drug as well as extended release tablet. So the use of Mao inhibitor is definitely not a first line therapy, but it is used in some very few cases when the other first line treatment and second line treatment does not help the patient. Now SSRIs, we have seen that they inhibits the reuptake of 5-HT and they prolong the disposal, or you can say they reduce the clearance of 5-HT at the synapse, and this is what their basic mechanism. And the 5-HT available at the synaptic cleft, it interacts with both presynaptic receptor as well as postsynaptic receptors. So the presynaptic receptors are 5-HT1A, 5-HT1D and 5-HT7, whereas postsynaptic receptors are 5-HT2A, and this effect on presynaptic receptors causes downregulation, whereas effect on the postsynaptic receptor, it influences the noradrenergic neurons. So 5-HT in the 5-HT in the serotonergic neurons by their effect on presynaptic and postsynaptic receptors, different kinds of 5-HT receptors, it causes the antidepressant effects. The common drugs are fluoxetine, paroxetine, fluoxamine, sertraline, citalopram and escitalopram. Now coming to the SNRIs, they inhibit both 5-HT as well as noradrenaline, but they affect more noradrenaline than 5-HT. It enhances both neurotransmission serotonergic as well as noradrenergic. It also affects the BDNF, that is brain-derived neurotrophic factor, and the mechanism is by reduced clearance of 5-HT as well as noradrenaline at the synaptic cleft. The drugs for SNRIs, under SNRIs are venlafaxine, desvenlafaxine, duloxetine, milnacipran, and levomilnacipran. So all these drugs are quite commonly used in the treatment of depression. Now, besides these SSRIs, SNRIs, there are a few 5-HT2 antagonists like trazodone, nifazodone, mirtazapine, and pianserine. There are also, I would say, a reserve drug, not very commonly or regularly used, but yes, in some patients where there are some specific type of symptoms, these drugs are used. Like mirtazapine, it also blocks 5H1 receptor, it blocks 5-HT2 receptors, and it also blocks 5-HT3 receptors. And these mirtazapine and pianserine, these two drugs have got quite significant sedating effect. And so the patients of depression who have got insomnia as a major symptom, these two drugs are very commonly used by the psychiatrist. Then there is another group of drug which inhibits the reuptake of both noradrenaline as well as dopamine. Now this drug is called bupropion. Bupropion is, I would say, not a very preferred antidepressant drug, but it is used sometime in combination with either other antidepressant drugs. It is also used for the treatment of smoking cessation and certain users which are like ADHD, attention deficit disorder, neuropathic pain, and also for the weight loss. So bupropion has got a very specific use other than depression in some of the cases. And the important point about bupropion is that bupropion metabolite is actually active. As a bupropion is not an active drug. Vortioxetine is also a very specific antidepressant drug, and this has got a multiple complex mechanism. It inhibits the reuptake of 5-HT. It is a partial agonist at 5-HT1A and 5-HT1B receptors, and it is antagonist at 5-HT1D, 5-HT3 and 5-HT2 receptors. So basically you can see that this drug it doesn't fall into the categories of the conventional antidepressant drug having multiple complex effect mechanism to work on depression. Now this is a derivative of ketamine, that is S-ketamine, which is available as a nasal spray for the treatment of depression along with other drugs, especially what we call as treatment-resistant depression. When other drug fails, this drug can be used in a very, very specific manner under the guidance of an expert. And as we have discussed that this is an NMDA receptor antagonist. How does it work in depression is actually not well known. Now, after this, in subsequent presentation, we will talk these medicines, these drugs which we have discussed, and their specific role, specific uses in various situations of depression. Thank you.